What's up? Doc Mike. Public Health on Call. By Johns Hopkins Bloomberg School of Public Health. Today's topic for March 16, 2021. Equity and the Pandemic with Lisa Cooper. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Facebook Live for Public Health on Call. I'm Josh Sharfstein, one of the hosts, and I'm so excited to be joined by Professor Lisa Cooper. Dr. Cooper is the director for the Center for Health Equity. She's also the director of the Urban Health Institute at Johns Hopkins, as well as a Bloomberg Distinguished Professor in Medicine, Nursing, and Public Health. Dr. Cooper, thanks for joining me.
Thanks for having me, Dr. Sharfstein.
So I want to start with a pretty basic question. You have studied health equity your career. You're one of the national experts in this topic. How do you think of health equity? What does that mean?
It's been defined in a lot of different ways, but the way I think about it is that health equity is when every person has the opportunity to be as healthy as they possibly can and to achieve their full potential. And nobody is disadvantaged from doing that because of socially determined circumstances. So things like, income and race or ethnicity or, their physical ability or something like that.
So looking back on the COVID-19 pandemic, is it fair to think of this experience in the United States as almost like a masterclass in health inequity? Because we've seen that people with certain circumstances have had trouble at every stage of this pandemic. I mean, we could even go back a year and just think about the trouble people had with testing, for example.
Absolutely. I would say that, what the pandemic did was just made very clear for everyone to see the inequities that we have in our society that are there all the time, but they were just magnified by the pandemic. So, there were certain people, as we saw, particularly racial and ethnic minorities, people in communities of color who were more likely to get infected, had many higher rates of being hospitalized and higher death rates. They struggled with not being able to get access to testing and to treatment. So I would say definitely we saw it all play out in front of us. There were issues that were underlying and that were there all the time. But with something like COVID-19, that sort of, really exposed issues like not being able to have a safe place to stay at home, having to go out and work when everyone else could stay at home, not having access to information, things like that.
So let's break it down a little bit further. So one of the challenges for equity was that certain people were more likely to get COVID for reasons that had to do with their social circumstances. Would that be fair?
Absolutely. Yeah. So there are people who had essential jobs. So basically had to go out and work, had to take public transportation, didn't have their own cars, lived in homes where they didn't have enough space to spread out. So even if, one person became ill, that would mean that the entire family would get sick. And in many cases, it would multiple generations of people. So even if there were young, healthy people who were out working, they might come home and spread the infection to their older relatives. We had people who didn't have access to running water, even, on the Indian reservations, for example, who couldn't wash their hands as often as they might want to. People didn't have masks. They worked in jobs where they didn't get masks to wear, or didn't have hand sanitizers, or had to be in crowded conditions at work. So there were lots of things like that. Or they didn't have access to health insurance. So even if they became sick, they were afraid or hesitant to try to seek healthcare.
Well, I want to ask you about that. So let's say people were more likely to get sick, but then their access to care might have been less. And health insurance that you just mentioned is one reason. What are the other reasons that people have difficulty accessing the healthcare system because of social circumstances or, conditions like race?
Right. Well, I mean, we have people who, like you mentioned, don't have health insurance, but there are also people who might have health insurance, but it's not really great coverage. And so, it's only for sort of catastrophic things happening to them. So they don't have a regular doctor that they can call on, to ask questions, or some place to go. They might not have internet access, and right now we knew that during the pandemic, a lot of in-person healthcare was transitioned over to telemedicine, and so some people didn't have access to internet or didn't know how to use patient portals and things like that that they would need to use to have a virtual health visit. Sometimes people didn't speak the language, and so in many cases, during this time, it was really hard to find someone who could speak your own language to basically help you navigate the whole system. And people were being told to stay away from healthcare systems and only to come in if they were, very sick. And so people were really afraid to go in.
And so the net effect of this was not a small increase, but a very large increase in the number of people in certain communities who got sick from COVID and died from COVID. I think adjusted for age, essentially a threefold increase in death. That is just an enormous, not a 30% increase, but a 300% increase, depending on what was going on. Did that surprise you as someone who's studied health equity and these types of issues for so long?
Unfortunately, I wasn't surprised, actually. I would like sort of waited with, sort of bated breath when I heard that there was this infection that was spreading throughout the world, and that it was, first, seen in people who had traveled overseas. But I knew that as soon as it got into the community, that the people who were most vulnerable were going to be most likely to be at risk for getting it at higher rates, being sicker with it, and then dying from it. And so, the increased death rates haven't surprised me at all. I mean, I think what's been really sad is to see that, life expectancy for our entire country has gone down by an entire year in the first half of 2020, but for Black Americans, for Black men by 3 years, and life expectancy for Black women by 2 years, and similarly for Latino Americans. So, and I'm sure the same, once we have the data in place, we will see for Native Americans who have really died at almost, as you mentioned, 4 times the rate of whites.
It's really the sum effect of all these different factors leading to essentially, a total disparity in life and death in the United States.
Absolutely. And then we have, not only are people dying from COVID, but they're dying from other conditions that aren't being treated during this time as well, because, the healthcare system has been sort of overwhelmed with dealing with patients with COVID, and therefore people who have heart disease and diabetes and cancer and strokes are also not getting care at the rates they ought to be.
And particularly, perhaps people who don't have the greatest access to care now have, even in good times, have even less in the middle of the pandemic. Now we've got some vaccines out there, and the vaccines are highly effective. But one of the themes emerging from the first couple of months of vaccination is that even though certain communities have died, have gotten sicker more, they're actually getting less vaccine. Have you noticed that too?
Yes, we actually have seen that. So, when we look at the data on who's getting vaccinated, for example, we're seeing that only, for example, 6% of people being vaccinated in the US are actually African American, when we know that they represent 13% of the population. Something similar, Latinos are representing something like 5% of the people vaccinated versus representing 17% of the population. So there is clearly a vaccine access issue, vaccine equity issue, and it's probably there are many causes that are playing a role here.
Let's talk about a couple of those in the few minutes we have left. It occurs to me that when there's a very difficult, confusing system of getting to vaccination, that people who are more connected, who may be able to spend hours of time refreshing websites, are going to be more likely to find that vaccine than people who may not even have internet access or understand the language, let alone, be able to go online.
And we're definitely seeing that, so I think, again, it's like we're seeing the same issue is playing out that we saw for healthcare being moved to the virtual setting. A lot of the vaccine plans have included signing up on a website. So, a person has to have internet access, has to have be able to navigate, computers, and has to know how to do all these things. That doesn't make it easy for people who, would prefer to use a telephone or really haven't even necessarily heard all the details about the vaccine and don't have anyone that they can talk to about it. Some people don't have transportation to go to the places where the vaccines are being distributed. So we need to make sure that we get the vaccines into the communities, into the familiar settings where people are, where they can get to more easily. So I think there are lots of issues here.
So let's talk about some of the solutions, because I know you have done groundbreaking work and solutions to questions of inequity and their applicability now to the pandemic. You mentioned one of them, bringing vaccine to people here in Baltimore. It's a big effort to have mobile vaccination clinics. Many of the hospitals, including Johns Hopkins, are participating in that, as well as the nursing school, with the idea of making it easy for people at highest risk to get vaccinated instead of having them jump through, different kinds of hoops. What else do you see out there that has, giving you hope that these are not inevitable challenges?
Right. No, I think the vaccine, the mobile units for vaccination are a fantastic idea. I think really, at the crux of this whole issue is connecting with people who are trusted in communities. So really working with, for example, faith leaders or owners of small businesses that are well known and trusted in the community, or local health professionals, providers, and trying to see if you can set up vaccination sites at those places, at churches, for example, at barbershops or beauty salons. Of course, you would still have to transport the staff who are trained to deliver the vaccine there, but putting it in a place where people feel comfortable going, where they know where it is, the people who are there can sort of help to share the message about the vaccine safety and effectiveness. I think making it walk-in and not having people to have appointments ahead of time, and also like making sure people have phone numbers that they can call. Maybe in some cases, sending people from the community door to door, community health workers who work for community-based organizations, to pass out flyers to let people know when these events are happening and where they'll be, and working with transportation companies like Uber or Lyft to make sure that some people get free transportation.
Some of those strategies have been used to help get people into treatment for high blood pressure, or make sure they get their treatment for cancer, diabetes. And what you're talking about is using those strategies, really a community-based approach to make sure the vaccine is available. I know also some of those strategies were used to expand access to testing in a number of cities.
They were, and they were very helpful in doing that. And these are lessons I think that can be carried forward not only for COVID, but for a lot of different health conditions and social issues that we need to address. I think that we, on a national level, need to invest more in those kinds of services and supports for people. But I think, at this time, it's critical for us to really rely on those relationships between health systems and between people in communities to kind of mobilize people at the grassroots level, to get involved in this.
One thought is, as that starts to happen, hopefully as more people pay attention to this, that momentum can be used to tackle some of the more fundamental issues in health and health equity. If there's a mobilization now to get mobile vaccine clinics, maybe that will lead to, more community health centers, more understanding of the transportation challenges that affect people so that they can get to jobs and other things that really are fundamental to health.
I agree. I think that, probably more now than ever, we're seeing that a lot of the solutions to these problems are within those communities. And that's who we should be listening to, because they can tell us what the real needs are, and that, it shouldn't all be a top-down approach, but it should be everyone sort of involved and really listening to people who are living with these conditions and kind of know what the strengths are within their own communities to help to solve these problems. And I think the other thing that this has shown us is that we're all connected. And because we're so connected, these issues should be important to everyone, not just the people who live in the communities that are impacted. But as we know, because those communities have been so hard hit, our entire country has actually suffered as a result, and our economy. And, it's really caused a lot of, sickness and loss, financial, economic issues, mental health issues for our entire society.
Well, we hope that the legacy of this pandemic is not just more, more divides, more disparities, groups being treated differently, and these horrible declines in life expectancy. We hope that the legacy includes doing things differently in a way that really addresses some of these fundamental concerns of health equity.
That's certainly my hope. And I'm optimistic because I really have seen people coming together during this time and seeing how that we're in this struggle together. And even though we may have different challenges, it's affecting us all.
Well, Dr. Cooper, you're an inspiration to me. Thank you so much for joining me today for this special edition of Public Health on Call.
Thank you for having me again, Dr. Sharfstein.